pleasure to introduce Andreea Seritan. She is a health sciences clinical professor here at UCSF. Came to us from UC Davis, what, 4 years ago or so? Two? Oh, it seems like so. Yes. She completed her residency at Baylor and a geriatric psychiatry fellowship at UCLA, and currently works here primarily as an embedded psychiatrist in the movement disorder clinic, and then is the clinical director of the PABI program here, the Psychiatric Assessment and Brief Intervention program. Her main research focuses on the psychiatric and cognitive effects of Fragile X associated tremor ataxia syndrome. Do the people say FTAX? FTAX, and Parkinson's disease. And she is a model clinician educator for our department, both in her dedication to teaching as well as research productivity. And lastly, one of my favorite colleagues, and someone I have very much enjoyed getting to know the last 2 years. So I look forward to hearing her talk on seeing things that others don't see, unconscious bias in acute psychiatric setting. So thank you.
Thank you so much. Thank you so much. Thank you all for coming. Oh gosh, wonderful. So can people hear me? Is this okay? Because I don't mean to yell. Okay, perfect. Do you know you've been in a place way too long if they think you've been here for 4 years when you've actually been there for only 2? But thank you so much. It is a pleasure to be here. Thank you so much for inviting me, Dom. This is actually one of my favorite topics, seeing things that others don't see or unconscious bias. And we have a talk structured in about 3 parts, so I hope I can keep your attention, but feel free to interrupt at any point. And then before we start, we are going to have an interactive piece somewhere in the first 10-15 minutes. Is that okay with everyone? Are you going to be okay feeling safe to discuss whatever gender bias you might have? It's about gender bias in that part because we are being recorded. Okay, perfect. Thank you so much. That's wonderful. Thank you, thank you. And of course, those of us who safely sat in the back are very happy and they have no problem with that. Okay, so first of all, we want to talk about what unconscious bias is, which by now I think is pretty well known to most people. I started looking into this and learning about it actually in 05-06. It was my first year or very close after I started my first job as faculty member in a department of 75 faculty members, 6 of whom were women. And then the rest were men, to be clear. And for this talk in particular, we want to reflect on the impact of unconscious bias in psychiatric care, so that's what I was asked to focus on. And I can tell you that there isn't much out there actually focusing particularly on psychiatric patients and mental health providers. There is bias from non-psychiatric providers, which we're going to talk about. And then learn some strategies to address unconscious and other types of cognitive bias. Does that sound good so far? Good so far? Very good. Okay. I have to tell you, I have no relevant direct or indirect financial conflicts. I wish I had, but not on this one yet. No, I didn't wish I had. Okay, so what is bias? Anyone know? Anyone wants to venture definition? Your thoughts? What is bias? It's not an ism, right? So you know that much so far. When do we talk about bias? When do we mention bias?
Hopefully often.
I was going to say, every day. Right. So here are some examples from actually the previous Olympic Games. I couldn't find anything. Also, I didn't have much time to watch because I was preparing this talk. But I couldn't find anything from the most recent Winter Olympics. But the Rio Olympics in 2016 gave us ample opportunity. Wife of a Bears lineman wins a bronze medal today. One might wonder what's her name and who is she and why did she win the bronze medal? But we do know that she is the wife of someone who must be important because this is Chicago Tribune. And then this one, actually, I have to tell you, my family, who's been around me for as long as they've been around, found this one and helped me. Michael Phelps ties for silver above the fold. You know what it is, above the fold in a newspaper. But Katie Ledecky set the world record in women's 800 freestyle and won a gold medal, and she is below the fold. This is August 2016.
In smaller font.
In smaller font, thank you, Blakely. Yes, exactly. So examples like this that you see all the time, hear all the time, and once again, maybe more often now we pay attention. When I started looking into this, we weren't longer than a decade ago. And so I had to learn about this. So bias is not an ism, it's not sexism, it's not ageism, it's not racist. What it is an unconscious stereotype. So social stereotypes about certain groups of people that we form outside of our conscious awareness. And the reason we call it implicit or unconscious bias, because the implicit memory that you may all be familiar with has actually a mechanism of storage and being accessed that's unconscious. So that's implicit. That's where the name comes from. I was just reading a recent 2017 review article from someone that said, we don't really know what implicit is. We do know what implicit is. It is unconscious, as opposed to the explicit memory, the conscious storage and access, retrieval mechanism. We know that, right? We do? We're good on that? Okay. So I'm going to use unconscious or implicit interchangeably throughout the talk, just so you know. So, very good book that I highly recommend. If you haven't seen this one from Malcolm Gladwell, Blink, he is the author of The Tipping Point. Blink came out in 2005, I think, and really opened my eyes. No pun intended or pun intended there. If you've read any of his books, you know, he takes research that's pretty complex, makes it very easy to digest. I would highly recommend this. He talks about the fact that we form impressions of people within 10 seconds of meeting them. As we're going through this, please keep in mind that this is true for our patients too, not just us, friends or families or people, you know, students, learners of all levels. Our patients form impressions of us at the same time as we form the first impression of them in the first 10 seconds. The best known test for identifying the implicit bias is the IAT, the Implicit Association Test. How many people are familiar with this or have taken it? Okay, not too many. That's good. So that's actually good because we're trying to learn something new. So some of us are very familiar. It exists, so it has all kinds of versions, all kinds of languages for race, for age, for gender, for people who are overweight, for smokers, for anything you want. And here's the thing, it's been done now by many people. They collect all the data on this website that goes to Harvard, and they actually have shown that most people have a form of bias or another. Most people have some type of bias, which I'll show you in a moment, I think, about yourselves, hopefully. I have to tell you, I've been giving talks on this since 2005 or 06, and people are always surprised, so please don't feel like you're alone if you're going to discover you have some type of gender bias, which is what we're going to do. So, newer book, Blind Spot, very good book. I'm about halfway through it, haven't quite finished it. But I do want to tell you, if you haven't seen this vignette, has anyone seen this vignette before? Okay, some of us have. So if you haven't seen this, let's go over this and let's see what you think. And I'll read it to you, or you can read it for yourselves. What do you prefer? Go ahead, Seritan. Very, very good. He's my boss. I just found out I report to him, actually. So I'm very respectful. So a father and his son are in a car accident. The father dies at the scene, and the son, badly injured, is rushed to the hospital. In the operating room, the surgeon looks at the boy and says, "I can't operate on this boy. He is my son." Who is the surgeon? I'm impressed. Yes, so did you hear that? What did you think? What did other people think?
Well, at first I thought it was his father.
And?
Well, that didn't make sense because it says the father dies and they are in the car accident together. But In fact, my brain went to thinking, well, his father must be the surgeon. No, that's obviously wrong.
Mhm. So beautiful example of recognizing the bias that it's there, right? So there must be a man who's the surgeon, right? Anyone else? Anyone else wants to share what they thought?
You could have two fathers, for example.
Yes, he could have two fathers. Actually, I have to tell you, this was me. When I saw this about 2-3 years ago, my mind it was so much easier for me to think that there are two men who are one of them is the surgeon in a same-sex marriage. I was so convinced that here I am saying that I studied gender bias. So yes, so it's very hard, right? There's an automatic connection, which is exactly the implicit, the unconscious aspect. It's an automatic connection we make. And so yes, after some rerouting, some cognitive rerouting, we're thinking it must be the mother or the other father. I completely agree with that. Okay. Because we're talking about this and some of us are here at the podium, I have to share with you my blind spot. So I'm reading this book. The authors are Mazarin Bonaji and Anthony Greenwald, and you probably see what's coming. So I was curious who they were. And actually one of them is the grad student of the other one. They gave this very nice explanation. The two of us met in Columbus, Ohio in 1980. They've been working on this for a while when Mazarin arrived from India as PhD student to work with Tony at Ohio State University. And I read through the book and I get to about page 71 where they say, Mazarin remembers much to her chagrin. And I was like, oh, Mazarin is a woman. Never crossed my mind. It's true that I'm not familiar with these names, right? Never crossed my mind in the first 70 pages. But I was curious. I did actually read the foreword. So, do we have blind spots every single day and working on presentations like this? Well, at least I do. And quite a few, I'm pretty sure. And the reason they're blind is because we don't know they're there. So on this note, I would like you to take on paper, so it's very easy, for those of us who've taken it before, you don't have to, but it may be helpful if you want, to take a gender ID. And the reason it's gender is because that's what I've been doing for a while, and I've done it with other people. So what we're going to do, we're going to pass the handouts. Please don't look at them for a moment until everybody gets them. And if you need pens, we also have pens for you. And whenever everyone has a handout, either make eye contact or raise your hand so I know you do. And then I need to time you. So that's why I'm asking you to please not look at them just yet. Thank you. So I'll pass some around. And then maybe we'll give you some. And I know you've taken it before, so after you, if you want to take it. You're good? Okay. And so let's pass this around, and we hope you have enough for everyone. No, I'm kidding. Okay. Anyone else needs a handout? Good? We're good? Everybody has them? Okay. Everybody has pens? We're good? We're ready to go? Okay. So the one thing, I need to show you how technologically literate I am. I have to start my timer. So, okay, ready? So the task is, in the central column, you have a list of names or nouns and names. Please make a check mark to the right or to the left where you think they belong. There are two columns, right or left. You don't have to do anything complicated. Just put the check mark to the right or to the left where you feel they belong. And I am gonna time you. When you're done, look at me or raise your hand so I know you're done as a group average, okay? Ready? Okay, do the first page only. Do not turn the page. Very good. So about 10 seconds, 10 to 15 seconds on average. We have an overachiever there who's very, very fast. Okay, perfect. So now we're going to do the same thing. You have a list of nouns and names in the center. Place them in the right-hand column or left-hand column by putting a check mark. And you can start now. That is the task. I'm sorry, I don't know how to stop. So about 35 seconds, I would say, on average, 35, 40 seconds. Okay. Are we about done? About it? Good? Okay. And now we can do the third page the same way. Place them to the right or to the left, wherever you feel they belong. Okay, so overall about 20 seconds on average. So we got 10, 15, 35, 40 seconds, right? And then 20, 25 maybe. So what are people's reactions? I see whenever the med students have something to say to each other, that's a good thing. Do you want to say anything about how it felt or what was confusing? Or was it confusing?
Yeah, it was confusing having two words in one spot and then trying to dissociate the two words from the genders in general.
Very good. So you felt like you had to dissociate. And it's the or, right, that was challenging to make the choice, okay? Okay, very good. So that's Jordan for people who don't know her. She's an excellent medical student. Blakely, I heard you say G's on the second one. Is that good, G's?
Oh, I don't know. I just was doing the same thing. I was associating the words that aren't names with male or female characteristics instead of them being family or career.
Beautiful. So your mind goes to male or female characteristics that may be behind those, that are attached, that are associated, and they're ingrained. That's why it's so hard. You have to stop yourself and take a step back. Anyone else, Damien?
I've taken tests like this before, and I'm always struck by it. I pretty quickly figure out what it's trying to do, but it's still harder for me. It still takes more time. Even though I know why it's making me take more time, I still take more time doing it. It's still slower.
Yeah, it's slow.
I'm still inhibiting more automatic responses. I think
Beautiful.
It's happening.
Beautiful, thank you. And question for you, since you've taken it before, do you think it helps to take it repeatedly? Will you get better? Will you get faster?
I mean, I think on each test it's like the Stroop test. Like once you figure out what it's doing, then you just come up with a workaround.
Yeah.
You can probably come up with a workaround, but that's not the point, right?
That's true, I never mastered, yes. But yes, I agree actually. Did anyone else, I'll get back to that point about practice, helping us learn or dissociate the automatic.
If you inhibit the automatic response enough, it becomes less ingrained.
It becomes less, I agree. Anyone else wants to add? You finished and tell us your name so we know who you are. Sam.
I got into a groove on the first one, and so I actually found starting the second one harder because I'd kind of trained to do the first task, so it was kind of jarring to then flip back.
So you have to stop and think about it a little
Right.
bit more. It's not the automatic response. The automatic response causes some kind of cognitive dissonance, as Blakely said. I agree, and that's why the second page is in the middle, and then you go back to another one that's a little bit easier, right? That more automatic responses are associated with whatever it is, female or family, and male or career, right? I haven't looked at it in a while. Very good. Anyone else wants to add their thoughts or their reactions on this side? People hiding in the back? Maybe no?
Similar experience, as was already mentioned. You know, it's funny, my brain was like, I don't understand the directions. That's the first thing I thought, that, you know, like, that there was a choice between male or family, that they didn't go together, they didn't have to be both at the same time.
Yeah, yeah, beautiful.
That was unclear.
Beautiful, yeah, like you said, and people actually wrote, they get, in Blind Spot, I would recommend if you were gonna read one, read Blink, which was my first one on this topic, but if you want to read another one, read Blind Spot, a second one. And they talk about that, how the Harvard people gave this test to so many people, and at some point someone wrote and said, your test is wrong. I couldn't possibly favor, in this case, was an African-American person, writer, saying I couldn't possibly favor someone else over Oprah because she's my idol. And yet the test is not wrong. The test shows the power of the unconscious, automatic assumptions we make every single day. So the reason this is important is because you have to experience it, but you can take, once again, feel free to go back to the IAT website and take as many as you want. I'll give you another very quick example of my own. Oh, by the way, I scored poorly on it. Not poorly, it's not good or bad, right? It's just that you spend more time. So you're like, okay, you're learning. But then I got better. Actually, I went to my husband's company party 2 years ago, and they had one of these with cards. You could put the cards in a pile. And I got so quick at it, and I was like, wow, I learned something. And then my husband, no, he's good. He's good because he's married to me, has to put up with all this all the time. So he did okay too. So, okay, so thank you very much for that. So as we talked about, there is implicit bias in all of us. Actually, I'll show you just a few studies, but this one I believe is famous. If you haven't heard of this one, I think you can read the paper or you can just take my summary. So they took about 300 residents in internal medicine, emergency medicine. They gave them the IED for race, and then they gave them a vignette describing someone who was presenting to the emergency room with acute signs and symptoms of an MI. There was no explicit preference of white over black. There was no explicit preference. No one said, particularly, we prefer to treat white patients. However, there was an implicit preference favoring white Americans, and those are the IED scores there. There was also an implicit stereotype expressed of black Americans as less cooperative with medical procedures and less cooperative generally. So in the end, when you draw the line, the higher the pro-white implicit bias was, the higher the risk that the African-American, this was a vignette, not real patients, that the African-American patient was not going to get the treatment for the acute MI thrombolysis, but the white patient was going to get. And once again, this is one of the first studies that brought it to our attention about a decade ago, that the implicit bias can hurt people, can actually cause, it was discovered that it can actually cause different outcomes in healthcare. More studies on this, but just very recent, 2 recent systematic reviews show that healthcare providers have about the same level of implicit bias for race, age, socioeconomic status, and I think I missed the gender there, as the general population, and that this bias is likely, the association was not strong on this one, but is likely to affect clinical thinking, decision-making, and patient care outcomes. And then this last part is a little bit sad. The mental health professionals, actually, they, in some studies, had good positive attitudes, implicitly held attitudes towards mental health patients. In a newer study, that was not the case, which goes to say that we may hold some of this. And then in the first one that was positive, actually, we tended to overdo things. We tended to want to overtreat our patients because we care about them and maybe we feel other people don't as much. So mixed results, take it with a grain of salt. Primary care physicians, remember what I said about patients feeling and forming the same, they have the same 10 seconds we do to form an impression. So primary care providers that were actually shown to have greater implicit bias against Black Americans were rated lower in their visit communication and the patient-centered care by their Black patients compared to white. So these are real PCPs. Now we're talking real care, not vignettes, nothing theoretical. Older patients, for example, were less likely to be advised to stop smoking compared to young patients. And there's a lot of data on older patients not being able to treatment for coronary heart disease, for all kinds of things. I just chose a few. And then this one, I like this one. The middle-aged women were twice more likely to receive a mental health diagnosis when the PCP couldn't figure out exactly what was going on. And what was going on in that vignette was actually coronary heart disease, and the PCPs were significantly less likely to diagnose that correctly or to be certain of their diagnosis. But they were more likely to give them, twice more likely to give them a diagnosis of perhaps generalized anxiety disorder. And for all of us who practice outpatient in particular, you know you have your patients who were probably having a panic attack, but potentially having a heart attack. Who are maybe not treated appropriately in the emergency room. So even more sobering data and difficult to digest as I was getting ready for this presentation. I looked for evidence that there is bias against psychiatric patients, and I phrased it intentionally. I looked for evidence, so I was looking for articles to show this, right? Because if you look for something, you are going to find it. Well, we'll get back to that in a moment. So there are actually some studies that show that individuals with mental illness are less likely to undergo catheterization or revascularization procedures after an MI. PCPs have negative perceptions of psychiatric patients and of psychiatrists. They actually think we're not balanced. 85% of people in a study thought that we were not balanced. You still have a chance, you're medical students. And then from our own colleagues, Dr. Peter, if you know Peter Ureste and Tammy Duong, who were our geriatric psychiatry fellows and are now fortunately on the faculty, when they were residents, third-year residents, they took 15 family medicine residents and they did a very nice educational intervention. And prior to giving them that educational intervention, they asked them, how many psychiatric patients do you want to see? Fewer, just about the same, no preference, or more? Well, guess what? No one said more. And not even after the educational intervention. This is just the pre data, not the post. It's about the same. No one really, maybe one person wanted to see more psychiatric patients. So that's sad. And then this one, and then I'm going to stop with with the difficult data. Patients with schizophrenia admitted to medical surgical units have twice higher risk of hospital-acquired infections, respiratory failure, sepsis, or DVT compared to those without schizophrenia. So you probably want to know why that is the case. I don't know that we know exactly. And of those who had respiratory failure or sepsis, they also had twice higher risk of ICU admission and of death. And then it costs more money, and they stay longer in the hospital. But the bottom line is they may have poorer care. Actually, they do have poorer care, according to this. So why is that? This is the counterpart to unconscious bias and a newer area that you may know about. I was actually very happy to learn more about for this topic, for this presentation. Daniel Kahneman. Anyone read the Thinking Fast and Slow? Yes, absolutely worth. Absolutely, it goes slowly. I'll say that. It has made me read a little bit more slowly. So he is a psychologist. For those of us who don't know who he is, he's a psychologist who won the Nobel Prize in economics because he showed how thinking processes, in particular this is called the dual process theory, can influence behavior, including what we do as consumers, but in general, behavior. So he and his very good friend and close collaborator, Amos Tversky, who unfortunately died before he could get the Nobel Prize, and you probably know that you can't get the Nobel Prize if you've died. They actually have a lot of research going back to the 70s, and if you would like to read now, this would be the fourth recommendation, The Undoing Process. It's a smaller book about their great friendship and collaboration. Type 1 fast type thinking or intuitive is the implicit one. That's where we fall in the trap, the unconscious. Associative, we rely on fixed patterns. It saves time. It will save time in an emergency situation. But it's not always good. It's not always bad either. And type 2 is the slow thinking, the analytic, deliberate. You actually have to stop, think, and requires focused attention. And they introduced this concept of heuristics, cognitive shortcuts that will help us save time, but also help us make decisions under conditions of uncertainty. And if you pause for a moment now to think, when was the last time when you exactly everything you wanted to know about your patient in order to make a diagnosis or come up with a treatment plan? Everything you wanted to know to be certain. It's never happened to me, and I've been practicing for some time. It doesn't happen, especially in psychiatry. There's a very high rate of uncertainty. It makes it very hard, makes it also subjective, and maybe why PCPs don't necessarily like us, I don't know, because they can't understand us. Jerome Groupman, by the way, a famous person, gonna come up on the next slide, in 4 slides, wrote a famous book, How Doctors Think. And he specifically says, everyone else but psychiatrists, because psychiatrists, I can't get how they're thinking. So imagine what that says, what message that gives. So I have some examples for you. We don't want to go over all of them, but just to give you some examples, we fall into these traps every day. If you think about the last patient you saw, let's make this exercise, mental exercise. Think about the last patient you saw just this morning, and think if you had any of these. So, representativeness. Making diagnosis based on the typical presentation. If it's atypical, you might miss it. You might miss the diagnosis if it's atypical. Availability, likelihood of a diagnosis is determined by the ease with which that comes to mind. Well, maybe it's been on the media a lot. Maybe you just saw a movie. Maybe you just saw Still Alice, and now you think everyone has early onset Alzheimer's disease. That actually would not be such a bad thing if you're thinking of that. Anchoring is the tendency to focus on information obtained early in the process. Someone gives you a piece of information. I'm saying, for example, that patient you're treating, Ellie, has Parkinson's disease, and now you're thinking must have Parkinson's disease psychosis, which I know it's not what you're thinking, but that's an example of anchoring, right? Hard to dispel later. Confirmation bias, tendency to look only for evidence to support, not refute your hypothesis. Remember what I said about I was looking specifically for studies to show bias against psychiatric patients. But maybe there are other studies that show that there is no bias. Has anyone done these studies? Well, probably not quite yet, because I didn't find them, but I didn't look hard. Search satisfying, the tendency to stop searching, stop the search for a diagnosis once you found something. You found something, that must be it, but maybe there's something else hiding. I'll give you an example in a moment. And then commission bias, I think when we're more junior, we tend to do this. I tend to do less of this. The tendency to do something, we ought to treat, we ought to increase the Cymbalta or do something else. But maybe you can also just not do something when they come to see you and just see how they're doing and maybe hold. I tend to do that a little bit more. Fundamental attribution error, the tendency, this happens a lot to the psychiatric patients, the tendency to attribute someone's behavior exclusively to internal factors. They must have done it to themselves. They were in that place on the bridge and they fell because they were intoxicated, but we forget the socioeconomic context and everything else that's around them. Overconfidence, that hopefully doesn't happen a lot, but I'm pretty sure it does, at least to me. And then this one is also important, and the reason I rarely put a diagnosis of personality disorder in the chart, because once you put a diagnostic label on the patient, it will stick to the patient and will stay there forever, and then who knows, maybe they're not gonna get the thrombolysis next time, you know, because you thought that they were, I don't know, annoying, and maybe the PCP will just assume, or the emergency room doctor will just assume. And then countertransference, we know this, they call it affective heuristic, and the base rate neglect is a good one. The tendency to ignore the true prevalence of a disease. It could be a lot more common or a lot less common than you think. The last one is mine, and in the interest of time, I'll skip it, but let me just say, when we are asked to see people who are clearly of great means, potential donors to this hospital or whatever, you're very intimidated, right? So what I do, how I deal, so I have my own blinders. How I deal with it is I try to make sure I do everything just like I would do it for everyone else. Actually, you know that VAPs get the worst care because of that. And doctors get the worst care because they're not very good patients also, and maybe because of that. So how many cognitive biases are there? Well, this study says there are over 100 cognitive biases affecting clinical decision making. And by the way, no one really knows the rate of diagnostic error in medicine. It is estimated at 10 to 15%. But are there really studies? Have people looked? Actually, people have looked. I want to make the point about experts like Damien, people who know like Andrew, who know very well what they're doing. They can recognize patterns. The more advanced you get, the more sophisticated, the more highly specialized, the faster you recognize a pattern. It is a trap sometimes. That's a heuristic, a failed heuristic. Whereas the novices around us, slow, deliberate, you have to think about it. Always keep your differential broad. You never know when that one thing that you weren't quite sure might turn back to become a more important, more acute issue. And I've said this already, and that's Dr. Goodman there. Okay, so I have a clinical example for you, and I think it's worth going over and thinking about it together. And I'll read it to you maybe, or do you want to read? Andrew, what say you? Can I read it?
Sure.
Oh, thank you. An 18-year-old woman is referred by her primary care physician for psychiatric admission for severe anxiety and depression. She has been having frequent episodes of shortness of breath, hyperventilation, carpopedal spasms with loss of consciousness. The admitting psychiatrist appropriately sends her to the ED requesting a chest x-ray to rule out pneumonia. In the ED, she appears to be in no apparent distress other than she says she's feeling breathless. She is obese, smokes cigarettes, has a history of asthma, and doesn't take any meds except for benzodiazepine and oral contraceptive pills. The physical exam is normal, the chest x-ray is read as normal, and she is cleared for psychiatric admission. While waiting for the transfer, she becomes agitated and short of breath. Several nurses try to calm her down, encouraging her to breathe into a paper bag. She loses consciousness again, codes, and cannot be resuscitated. And at autopsy, she is found to have pelvic vein thrombosis extended from the femoral vein and saddle emboli in both lungs, as well as multiple clots of varying age. And they do say, that pulmonary embolism is missed in over half of the fatal cases. So let's go over this again slowly together and try to think what happened here. What are the biases, the cognitive biases that you see? Of course, hindsight is 20/20. So any biases, and I'll go back, any biases that you can identify from the long list we talked about. If you don't know what it's called, just say what you're thinking.
Well, my bias reading this is actually, having had a case like this, that the ER dismisses these sorts of things right away, and someone shouldn't be passing out if they have panic attacks. So in fact, I thought from the start this person maybe has
Absolutely. Excellent doctor.
Worst bias.
Excellent
As a
doctor.
psychiatrist.
Representativeness, right? So the typical presentation, that's not a typical presentation. Not everybody who has a panic attack passes out every day. If that happened, the world would be full of people being on the floor half of the time. Or maybe not quite half, because that's not the true prevalence of the panic disorder. But yes, thank you. So the presentation is not typical. And also you said this is dismissed all the time because they're psychiatric patients or because...
Yeah.
Okay, so from experience, speaking from experience. Anything else? Anything else in here, Damien?
The radiologist is anchored to pneumonia.
Very good,
Right.
anchoring. Very good. The ED doc, in this case, or the radiologist is anchored to pneumonia, anchoring. You said something, they were like, that's it. How about anything else they could be anchoring onto? Early on, information given early on in the first sentence.
Age.
18 years old.
And
Age.
anxiety.
And anxiety. They said 18-year-old with severe anxiety and depression. And that's it, you're anchored. This is anxiety. Even if you're not thinking that consciously. Very good. Anything else? So we talked about representativeness or the opposite, anchoring, maybe availability, maybe they see this all the time. I don't think they see this all the time. Hopefully they don't see this all the time. But they did not recognize the presentation is atypical. That's why this diagnosis is missed. Because the typical presentation with the shortness of breath and whatever you're supposed to have on the chest x-ray actually occurs only in half of the cases. Anything else? Are the novices, were you more concerned?
Well, typically you wouldn't see anything on a chest X-ray for a PE unless it's like a very bad one. She has a lot of hypercoagulable risk factors.
She does. She does. She has a risk factor.
And like
ICP.
cardiac, and
Yes,
also
yeah.
like they're, like thinking about causes of shortness of breath in
Mhm.
general. Like,
Apparently he thought the exam was normal. So the ED doc in here was a resident. I cut that from the case. They said the ED resident. This is actually a case from the paper. The other thing that
They did the oxygen side, right?
they did, yeah.
Okay.
Oh.
Yeah. No, I don't know. Actually, no.
I wonder.
I don't know.
I mean,
You wonder.
like, obviously they must have done that side.
I'm thinking so. How about this one?
Well, they didn't sort of just start over, in other words, when she starts
Yeah.
becoming agitated. And
Very
so they go
good.
straight to an intervention.
Very good. No one went back to the drawing board. Maybe this is not what we think. Maybe she's here, she's very agitated, but we try to help her breathe.
Also, I'm struck, I think if you just thought somebody in ED becomes acutely short of breath, would a paper bag be the first thing the ED staff would bring? Probably not, right? They would
I don't know.
probably do something else.
For the purposes of teaching, this case was written, but very good. So I think we've talked about all of those things. The representativeness, it was atypical, or the lack thereof. Anchoring, patient was initially referred for anxiety, and then they were thinking pneumonia. Search satisfying, they did the chest x-ray, it's not pneumonia, maybe it's not anything else. The chest x-ray was read as normal. Diagnostic momentum, the anxiety label stuck to the patient, and then yes, there is bias against psychiatric patients. We talked about that, and Dr. Budi knows very well. So this one, I think it fits in 15 minutes, and it's another interactive part, very brief, so maybe it's worth doing. But as we've discussed, so this moves into a little bit of a different direction, but as we discussed, patient-provider concordance on socioeconomic status, gender, race, ethnicity, even language, as you know, is very valued by the patients. And there are ratings of higher visit, patient-centered care, and satisfaction. So what should we do? What should the diversity committee do? So we think that patients prefer to talk to providers who look like them, or maybe speak the same language, or maybe understand a little bit more about their background. But I'm here to tell you that the unconscious bias may, and the reason I said may is because things are changing in a very good direction, may affect recruitment and retention at all levels, including the medical student selection into honor societies. Now I'm not making eye contact because I'm thinking, what am I saying to the medical students? Faculty recruitment, tenure criteria, language, NIH support. So I'll just show you a slide per each if you can bear with me. Do you want to hear this part? Okay, so this is the part of the unconscious bias that I was actually most fascinated with when I started looking into this. So for this, I want to ask you to take a moment, clear your mind of everything we've talked about with patients so far, if you can, because I know it was disturbing. And think that you're a member of the search committee for the next chair of the Department of Psychiatry. And then take a moment, just a moment, without thinking too much, and create a mental image of the ideal applicant for that position. First image that comes to mind. And then tell us what it is. What do they look like? Emma, do you want to start? What does your ideal applicant look like?
White lady.
Very good, I'm impressed. She's been through a lot of counter-stereotypic training. Very good, white woman, okay? Anyone else? What was the first image?
think it's availability bias, but I just pictured our current chair.
Yes, of course,
Because
you
we said
picture your
chair of
current
the
chair.
Department of Psychiatry, so the image that came into our mind was just our current chair.
Exactly. For the students, they don't know who that is, but yes, the current chair is a male, white male. Yes. Okay. Anyone else? Anyone?
Oh, the chair of psychiatry I had was Hawaiian females.
Okay. Very good. Okay, that's very good. But what if you look around? I did this on purpose. Turn around. The portraits of all the chairs, except for one. They're all white men. And I could prime you to show you just Renee's portrait. This is the unveiling. I took a photo to send to my family because I'm so proud. And maybe if I wanted to prime you even more, I would cut the right hand and where you see no men, but just women. Maybe that will bring the image of a woman a little bit more closely to your mind. So isn't it interesting? And I love this. I have to say this is a perfect example. Okay, I did it on purpose. So medical student selection in the AOA, yes. After controlling for USMLE Step 1 scores, research productivity, community service, Gold Humanist Honor Society membership, anything you want, Black and Asian medical students were less likely to be AOA members than white medical students. And there was no difference in this study between white and Hispanic students. For faculty applications, for 8 junior faculty positions at this one school, they looked back for 8 years. They looked at all the applicants, all the letter writers, and they grouped the traits that you can find in the language in the paper as communal and agentic. And communal means affectionate, helpful, kind, sensitive, nurturing, interpersonal. I'll have to tell you, this paper made me really revise how I write my letters. Or be very careful when I say this person was very nice. Don't say that. They're competent and they're nice. Agentic, assertive, confident leader, intellectual, independent, daring, and outspoken. And guess what? Women were described, no surprise, with more communal traits than men. And actually, they gave these CVs, real CVs, to real psychology professors to rate applicant hireability. Would you hire this person for that particular position or not? And they gave them a number of letters plus 25 common to calibrate, controlled for letter writers' gender, and then the communal traits were, of course, negatively related to hireability. The applicant's gender was not. So what you say is important in those letters. I really seriously went back and looked at my letters. I can give you a lot more studies of this. Went back and looked at my own letters. Was this true? Yeah, I haven't worked with her in research, but yeah, I think she'd be good, maybe, I don't know. Those are called doubt raisers. I haven't done that, but I think that may be. Women's letters have more doubt raisers. And then this one is my favorite, rating applicants in the presence of a competing cognitive task, meaning memorizing a 9-digit number in 20 seconds, enhanced evaluation of men for leadership position, meaning men came on top, and the effect was most pronounced in female raters. So in other words, if I distract you and I want you to remember a phone number, the applicant, the male applicant is going to come on top. There are actually strategies, fortunately, for dealing with this. I'll tell you in a moment. Okay, this one also famous study, if you haven't read or don't follow this literature in academic medicine, they looked at all the R01 applications for these 6 fiscal years. There were 40,000 investigators. Asian Americans were 4% and African Americans were 13% less likely to receive NIH investigator-initiated, meaning you actually put the application in, compared to white. And then after controlling for everything else, applicants' education, training, country of origin, everything else, African Americans were still 10% less likely than whites to receive NIH research funding. So you wonder why there's less around us when you look around and don't see them in the faculty ranks. Tenure criteria is another very interesting field. This one study looked at the top 24 US medical schools ranked by NIH funding, so major research institutions. They looked at the women as percentage of tenured faculty during these years. Medical schools with the word leader in their tenure criteria were more likely to be below the median than those that didn't have the word leader. Actually, not this one, but other authors also looked at the NIH language and wrote to the NIH and said, we would like you to change the language to put more collaborator as opposed to independent investigator. And that has changed, actually. They were able to do that. It wasn't all the NIH, it was I think the CDSI, the CDSC first wave of grants that was analyzed. And that was because there was no woman principal investigator in the first wave of CDSI grants. Okay, more in that same realm, significantly lower salary, interventions. There are interventions. Yes, we can do counter-stereotyping training. For example, matching the gender, like exactly what we've done, matching the gender to counter-stereotyping words, or priming you with research showing they gave people in a study, they gave them a little article to read on a woman that was successful in a male-dominated field, and that helped them choose the female applicant. However, not one woman. So Renee, one. We need another one here, maybe. That would prime you if you're sitting in this room. Also, and I do this, and Dr. Budi knows this because we've sat together on search committees, always commit to the value of credentials before you start looking at applicant files. So first say, what's going to be important to us? We want someone who's going to be collaborative. Okay, check. We want someone who's going to be, I don't know, run a program, interdisciplinary program, check. And then apply those criteria exactly the same way, regardless of gender, but commit to the criteria before you even look at the applications. Because the moment you've looked at the first one, you've already been biased. So I do that, actually, for search committees I run, none here. Women 35% or more on search committees, women 25% or more part of the applicant pool. Otherwise, you're not going to get them, right? You get one. And then workshops on unconscious bias that is actually very clearly documented to increase hiring of women in academia. And then for you, what can you do? There's lots of strategies. The first one would be to recognize that we have bias. That's why we're talking. Take the IET if you haven't. That's going to be very helpful. I put psychotherapy, supervision, consultation, because those help us look inside and realize what are our blind spots. Mindfulness-based interventions go without saying. And actually there's studies on meditation, loving kindness meditation, showing that that reduces the age, race, bias, and socioeconomic actually. This study looked at bias against homeless people. And then there are a lot more to reduce, not particularly the unconscious bias that we talked in the first part, but the heuristics, the cognitive bias. First of all, surgeons, slow down. Slow down when you shoot. That's exactly what they talk about. In the OR, if something doesn't quite jive, they slow down and then they reevaluate the situation. Family physicians use these pause before knocking on to the next patient's room. Right? They're busy, they have 15 minutes per patient. Pause. I do that. I try to clear my mind between patients. Okay, next patient, clear my mind of the previous one, especially if you're busy back to back. Perspective hindsight, I really like this one. It's from the military, actually. Let's say you made a diagnosis based on the information you have, and then let's say you gaze into a crystal ball and look into the future and your diagnosis was wrong. So going back and think what could have happened if you missed the diagnosis. And actually terrible things could happen, like in the case we described. Metacognition is thinking about your thinking process. How do you recognize this? How do you recognize the patterns? What is it that you're missing? And there's so many other little strategies, such as ask yourself, do I have to make the diagnosis today? Maybe not. Maybe you can give yourself another visit with the patient. Do I have to make the diagnosis today? It's a simple thing. You don't need to. I actually very often give myself another visit to clarify. I may put an NOS or whatever that's called, unspecified, not other specified. There are papers particularly on cognitive bias error reduction strategies. I really love this one. The last one I really like. the fundamental attribution error that we said many providers fall prey to when they face our patients, it is, imagine a friend or a relative in the patient's position. Would you feel the same way? Would you feel that it's their fault? Because I don't know that that's going to be the case. But that really means pausing, thinking about it, being deliberate about it, and giving yourself permission to say, you don't know. The effectiveness of these interventions has been studied from 1 hour to 1 year longitudinal curriculum for residents, and those results are solid, showed significant improvement. Workplace interventions such as checklists, mixed results. And then the last word, mindful providers actually get better rating scores. Not that you care about the rating scores, but your patients understand, they have a connection. They feel that the patient-centered communication is increased, the age and race implicit bias is decreased, and then people who practice mindfulness do have higher empathy and compassion. And it decreases medical errors because of everything we've talked about, right? And then the last word on this, it's not just us. We can do mindfulness, practice mindfulness, but if we don't have the time to pause between the patients, if we feel that the volume is driving the quality, which it never happen. There are organizations, and highly reliable organizations, once again from the business world, comes into healthcare. It's going to come over the next 3 decades, I think, show that organizations that are reluctant to simplify, that rely on experts and adaptive experts that can change and be flexible, that allow people to speak up if they see something. This is mindfulness at the organizational level. It's not just the individual providers, and there's a lot more to be said on that. So in summary, I hope I've shown you that unconscious or implicit bias and cognitive bias heuristics affect clinical reasoning and decision making and may lead to diagnostic error and poor patient care, suboptimal treatment outcomes. Experts may be more prone to failed heuristics. Type 1, recognizing patterns, being fast, so always remember to be mindful, and that there are effective strategies, and we should learn more about that, and we should do more of this. And with that, I'm going to stop, and time's up, so maybe one question or no questions. Thank you.